We will be discussing the collaborative approach to public goods investment, CAPGI model. As part of this project, 11 investors in the Cleveland, Ohio area came together to explain the medically tailored meals program offered through Benjamin Rose's Rose Centers for Aging Well. This webinar will be recorded. You may submit a question at any time using the Q&A or chat feature at the bottom of your screen. We have staff monitoring each to convey your questions to our presenters and to answer any technical questions that you may have. You can turn on captions by selecting Live Transcript, the button with two C's at the bottom of the screen. Today, we have the pleasure of hearing from several experts in the field for a discussion of how the CAPGI model can address food insecurity and serve as a tool to finance, govern, and evaluate interventions in social determinants of health. First, we will hear from Mr. Bob Blancato, president of Matz Blancato and Associates, and the national coordinator of the bipartisan 3,000-member Elder Justice Coalition. He is also the executive director of the National Association of Nutrition and Aging Services Programs and the national coordinator of the Defeat Malnutrition. Mr. Blancato has long been recognized as a national advocate with policy expertise on behalf of older adults. He has testified numerous times between House and Senate committees. His prior work history includes 17 years as a staffer in Congress and an appointment by President Clinton to the executive director of the 1995 White House Conference on Aging, one of 4 he has participated in. He is a member of the Senior Executive Service. As a volunteer, Mr. Blancato serves as second vice chair of the AARP board and is also on the AARP Foundation and the board of the National Hispanic Council on Aging. From 2019 to 2023, Mr. Blancato served on the National Advisory Committee on Rural Health and Health Services. We will then hear from Ms. Dabney Conwell, who is the Vice President of Health and Wellness at Benjamin Rose. In this role, she is responsible for the oversight of all nutrition and socialization programs within 6 senior centers and the largest home-delivered meals in Northeast Ohio. The largest home-delivered meals program in Northeast Ohio. To address food insecurity and social isolation amongst older adults living with chronic diseases, Ms. Conwell designed Cuyahoga County's first medically tailored meals program. She is an adjunct professor at Case Western Reserve University in the Jack Joseph and Morton Mandel School of Applied Social Sciences. She teaches in the Graduate School of Social Work. Ms. Conwell received her master's from Case Western Reserve University in 2007. She holds a professional license from the State of Ohio Counselor, Social Work, and Marriage and Family Therapist Board. She is a Lean Six Sigma Green Belt. She serves as a director for the Center for Community Solutions and the National Association of Nutrition and Aging Services Programs. Welcome to each of these presenters, and I will now turn it over to Bob to get us started.
Wonderful. Thank you very much, Ashley, and good afternoon and good morning to folks, depending on where you are. I'm happy to join this. Let's go to the next slide. So today, the focus is on medically tailored meals, and the Elder Justice Coalition is honored, as always, to co-host these webinars with Benjamin Rose. Thank you to Orion Bell and Ashley for putting these together. This topic is very timely and very relevant right now. First, timely because we're in the middle of National Nutrition Month, and relevant because there's a lot of new activity in Washington, D.C. around medically tailored meals. I'm great to have 2 great friends and colleagues as presenters, Dabney Conwell and Len Nichols. So let me offer a few thoughts on this topic. Next slide. So the catalyst, in my judgment, of the recent activity was the White House Conference on Hunger, Nutrition, and Health that was held in late 2022, and I was happy to be a delegate. And, you know, there is a heightened interest now in medically tailored meals. That conference had as one of its 2 goals to improve nutrition by the year 2030. It was noteworthy that the 2 lead federal agencies that ran this conference were the Department of Agriculture and the Department of Health and Human Services, which really solidified the recognition of the absolute nexus between nutrition and health in this country. The conference did call for expanding Medicare and Medicaid beneficiaries' access to, quote, food as medicine, unquote, interventions like medically tailored meals, and then legislation for a pilot to test medically tailored meals in Medicare. Next slide. And we are happy that the Medical Nutrition Equity Act, HR 6892, has been introduced. And Congressman Jim McGovern, who was a national leader in nutrition issues in Washington for many years, his bill would cover medically necessary food and supplements for digestive and inherited metabolic disorders. And you also have the Medically Tailored Home Delivered Meals Demonstration Pilot Act, HR 6780, also introduced by Congressman McGovern, to do a 4-year demonstration program to provide medically tailored meals to eligible Medicare beneficiaries with diet-impacted disease. Next slide. And we have also the start of the Older Americans Act reauthorization process. It's down the road. Technically, it's supposed to be done this year. We think it still will get done this year because traditionally they reauthorize the Older Americans Act pretty regularly. And yesterday I spoke at a bipartisan Senate staff roundtable on the Older Americans Act, and I called for greater recognition and funding support for both medically tailored meals and culturally appropriate meals. This is the time, through a reauthorization, to modernize the existing nutrition program for not only medically tailored meals, but for culturally appropriate meals. This webinar and those who attend it can help us in our advocacy efforts to get this done as the Older Americans Act progresses. And then finally, on my next slide, Senator Sanders began the hearing, the chairman of the hearing, talking about the growth of malnutrition in older adults in this country, estimated to cost $50 billion a year. And he makes it as only Bernie Sanders can do, he makes a very logical point. It makes a lot more sense to spend money on food than on the emergency room, okay, which is where a lot of people with malnutrition end up. And so, since we see this growing concern about malnutrition in older adults, there's another opportunity to focus attention on these medically tailored meals. And it's about making sure the recipient gets the most appropriate nutrition to maintain and improve their health. So screening for food insecurity and malnutrition is an essential part of targeting food as medicine and MTM programs. So I want to thank you for the opportunity to open this webinar. And now it's my honor to turn it over to Dabney.
Thanks, Bob, and hello to everyone, and thank you for joining us today. You can advance to the next slide. Thank you. Benjamin Rose had positioned itself to do this work many, many years before we started it, but I want to frame just for the group here where we are and what our work is that positioned us for success. So Benjamin Rose delivered last year an estimated amount of about 167,000 meals, home delivered meals. And those were just in our senior centers, and then add another 3,000 in our congregate spaces. So we have been in this space of nutrition for many years, and it starts to shape why we were best fit to begin this a new opportunity. And hopefully you'll begin to see this picture as we run through today, what we did to position ourselves to be ready for the work with CAPGI. Next slide. So we thought about food in a continuum. And so again, to continue to shape this work, if we think about food on a continuum, to the left being the least restrictive and the right being the most restrictive for those who are food insecure, a food pantry would be an example of something that would be the least restrictive. Someone is able-bodied, they are able to go to a local food pantry, get fresh fruits and vegetables, and be able to go home and prepare those meals for themselves, excuse me. And oftentimes those are paid for, if you will, through a connection with SNAP. If we continue to move on the continuum, the congregate meal would be the next. So that is a location within a community where older adults are able to go to that location and take advantage of a nutritious meal through a provision of Older Americans Act dollars in many spaces. And then also, as an aside, or in addition to, have exposure to socialization opportunities and programs, whether that's formal or informal. And then the home delivered meals on the continuum food provision would be homebound older adults receiving a meal from a provider 5 days a week, hot meal that's prepared and ready to eat. But what we found what we saw that was missing in this continuum prior to starting our work was the medically tailored meal program or medically tailored meal provision. And so what that looked like for us is we were seeing that there are chronically ill older adults that are on the furthest end of that spectrum, were the most socially isolated, the most food insecure. And so our response to that was, how do we think about what we already have in place? Is the infrastructure, could it support adding of medically tailored meals? And we thought that answer was yes. And so we began this journey of exploring that. Next slide, please. So there were many things that we knew for sure, and some of those things are listed here in this these 4 points on this particular slide that we're titling the why. And so we knew, as many of you, I'm sure, on this webinar know, that it's the obvious challenge that foundationally food is the most important need of any human being. But then if you tie in chronic diseases, it becomes even more important if that is a thing, because we're looking at the dietary modifications that are necessary. So it presented a challenge. So that was the conundrum. The crisis, however, as we continue to think about and explore our work, was that healthy foods are more expensive and less accessible in many ways. And those that are least healthy are easily accessible. So that is what is in our spaces, in our communities, in our neighborhoods, what we all know to be as food deserts. We're showing up very strongly, very clearly. We also found in our work that the expensive medical procedures and medications are readily accepted than food interventions. So we could easily start to have conversations, and we did start to have conversations around, let's provide food to be more on the preventative side as opposed to medications. And then we started looking at what is the audience for this work. And we found that what you see here, that the count is that was a 1-to-3 ratio of chronically ill adults are unable to afford food, medicine, or both. Next slide. So we began to put together the model. And so we spent lots of time digging deep into some of what are the best practices. We took a journey to the to the New England area, in the Boston area, and started looking at where some of this work was coming out of. We had lots of best practices with that group, specifically the Center for Health Law and Policy Innovation from the Harvard Law School had really taken on this work as a policy issue and not so much as a program issue, if you will. And so they had really done lots of work in how do you acknowledge food as medicine, and what does that look like beyond just saying that food is medicine, and how do we put policies behind that work? Also doing lots of readings from Dr. Berkowitz, who has since done lots of articles and conversations and webinars on this idea of providing healthy nutrition has an impact on hospital readmissions. And he's since taken his work so much further than just that statement. So I have a link here for that we should share in the chat as we go through the rest of this webinar today. We intentionally focused, and there were lots of conversations internally about, should we do one over the other? So should we focus on food insecurity or should we focus on social isolation? And so we went back and forth between, should we do one or the other, or should it be both and we got to the point where we decided that it was both, because there was such a direct correlation between folks who were socially isolated and food insecurity and vice versa. We had many conversations if we should be looking at a frozen option only versus a hot option daily delivery. We had some initial funding that came from a local funder, Sisters of Charity, was a grant to support this work of doing all of these, answering of the questions of food insecurity, social isolation, whether we do both and or one or the other. We were able to launch with a local community hospital connected to the Cleveland Clinic here in Cleveland, Ohio, which gave us the opportunity to take all of our thoughts and put them to the ground. And what we eventually came to the point that we named Nutrition Solutions, which we'll talk about in a moment, because that became the intervention wrapped up in a package. And we had a true commitment to rely on what happened organically in the space after it came out of our offices and after it came out of our whiteboarding sessions around program design and implementation. And we had the flexibility to be able to do that because we weren't necessarily tied to the restrictive guidelines of something like federal dollars or Older Americans Act funding. Next slide, please. So Nutrition Solutions became the name of our intervention. We worked with, internal to ourselves, but then we started to reach out and have conversations with the hospital that we were working with. And we came to the point where we realized that really Nutrition Solution elevated the conversation around the intersection between food, socialization, and most importantly, this payer-provider CBO triangle. So what lanes, really starting to think about where does the intersection happen as opposed to them relying or each of us staying in our own lane with the client being in the center and attempting to navigate all of those things, but all for the same purpose. So the target population was adults 50 years and older. We didn't start that in that space, but we eventually got to that space for a host of reasons. But the one that I will highlight for this conversation is what our providers told us is that our payers, told us we're seeing some of the same health conditions in younger adults that we are seeing in our traditionally older adults. And so we opened up this program and we had the ability to do that because we weren't tied to a particular funding source that required us to have an age, a starting point for an age person that was higher. We initially started with what we call the big three, which was heart disease, hypertension, and diabetes. And then we eventually added in kidney disease as we, again, heard payers say, this is a pain point for us. It's becoming a larger pain point. And so we added kidney disease and we added a meal that met that. And then we had a screening for food insecurity and social isolation were the three elements that got people qualified to participate in our first and second implementation of the program. Next slide. So here are the program elements. So think about a three-legged stool. The first leg was the medically tailored meal, and that got to the goal of reducing food insecurity and making food available for this particular population. Those meals were different than our Older Americans Act meals because they were specifically designed based on the chronic disease, and we delivered those meals a total of 10 meals per week, whereas in our universal program, it was 5 meals a week. We did nutrition education that came directly from our meal folks, our dietitians, created these nutrition education materials that went directly when someone enrolled in the program. That material went right to them and it was specific to their chronic disease. And then the weekly wellness checks, which was the unique piece in that we wanted this relationship to be with a volunteer that had some training from us here at Benjamin Rose, where they would spend a minimum of 20 minutes per week having conversations with their assigned older adult, and that trained volunteer had some key points that they would listen for and then report back to us. We had some learnings that we'll talk about in the best practice section, but we had some learnings around number 3, which I won't hold us up with at the moment, but I'll certainly come back to. Next slide. So we had to also obviously think beyond the numbers. So not just what it was the data telling us, but what was the experience that our participants were having that were in the program. We were learning really quickly on that providing someone 10 meals that were medically tailored based on their diagnosis their medical diagnosis wasn't going to change or reverse their human behavior. It wasn't going to say, okay, now I'm going to start eating this way. And so we had to think about that the behavior change is the food that's grounded in one's lived experience. So if I've been eating this way for so many years, starting in this program isn't going to turn my life around right now, but it begins to the education and the foundation piece of how do we talk about nutrition in a way that we are making sure that we're not ignoring someone's lived experience. We then spent time thinking about the community aging in place. So allowing people, again, to remain in community where they desire to be and still being able to maintain the quality or standard of life that they wanted to have. I want to point out a couple of best practices that we learned. We learned that because we were starting that 50 plus, that group of folks are still in the world and they're working. And so they are not our traditional delivery recipient of home delivered meals. And so how do we accommodate someone who's 50 years old, has been referred by their provider? And so we had to adjust our delivery structure a bit to accommodate those folks. We also learned really quickly, this is on the backside, this wasn't necessarily client facing directly, but it had an indirect consequence that the payer and provider had a shared commitment that we were working and collaborating around together. When prior to this program, we were working in our own lanes, and that showed up differently depending on the scenario. We also took this a bit further. So because we knew we were enrolling people in the program based on the best practice of some of what we learned in the New England area, along with Dr. Berkowitz's research, that we knew that 6 months really was the number that we should be providing meals. 6 months was a solid number. That was all the research at that time was based on a 6-month delivery. But what we wanted to be really, really careful that we did not do was to say, okay, you're food insecure for 6 months. And then when you hit that 7th month, we're going to cut off all food to you and make you more food insecure than you were. And so we created bridge meals. So we were able to extend, thanks to the providers being willing to provide, cover the cost for this. We extended the medically tailored meal provision an additional 3 months with what we call bridge meals, where we moved someone from a 10 meal per week delivery to a 5 meal per week delivery. And then at that point, if the person met the qualifications for Older Americans Act, we enrolled them into our universal Older Americans Act provisions and programs, so that we were not cutting folks off from food insecure folks off from a meal program just because they hit the calendar that said 6 months. And I think the next slide is just my contact information. Yep. So I'm going to be kind to my colleagues and stop there to make sure they have enough time, but certainly we'll hang around for questions at the end.
There we go. Thank you, Dabney. I now have the pleasure of introducing Dr. Len Nichols. Dr. Nichols is a non-resident fellow in the Health Policy Center of the Urban Institute. He was the director of the Center for Health Policy Research and Ethics and professor of health policy at George Mason University from 2010 to 2020. He is the president of NS Ideas LLC, a health policy research and consulting partnership with his wife. He has been intimately involved in health reform debates, policy development, and communication with the media and policymakers for almost 30 years. After he was a senior advisor for health policy at the Office of Management and Budget, OMB, in the first 2 years of the Clinton administration. After OMB, Dr. Nichols was a principal research associate at the Urban Institute, vice president of the Center for Studying Health System Change, and director of the Health Policy Program at the New American Foundation before he moved on to George Mason. Dr. Nichols received his BA from Hendrix College in Conway, Arkansas, an MA in economics from the University of Arkansas, and received his PhD in economics from the University of Illinois. Please join me in welcoming Dr. Nichols.
Well, thank you, Ashley. I appreciate that. That's a kinder and longer introduction than I deserve. So let's jump right in. My task in life is just to figure out how to get Dabney more money. That's really my goal. And I have a good partner here in Jen Kahn, who you'll hear from in a moment. But anyway, with Lauren Taylor, a brilliant young scholar who's at NYU Medical School now, we developed a model. We call it CAPGI, Collaborative Approach to Public Good Investment. But what I want you to focus on is the puzzle picture and the word community, because what this model is really about, and you notice the same colored picture, piece of the puzzle that Dabney had, what this model is really about is helping communities finance things they can't finance any other way. And that's really why it's exciting. Next slide, please. And click a couple times. Okay, so basically it's true for lots of different interventions. You see housing, you see food, you see transportation, you see a group of people holding hands. That stands for complex case management. That certainly helps people. Click. It improves their health, it improves their well-being. Click. And that strengthens the neighborhood and communities and so forth. But it turns out any kind of activity upstream from healthcare, especially food and housing, is going to improve those people's well-being, but it's also, click, going to improve lower costs. It's going to reduce the use of ED. It's going to reduce the use of inpatient care. It might very well reduce law enforcement under certain circumstances. It's probably going to reduce employer costs because they'll have fewer missed days from work and school, missed days from school. So keep clicking. And that turns out to create benefit for multiple organizations. At the same time, you're helping those people. And that notion of creating benefit for multiple people and multiple organizations at the same time leads to both an excitement because everybody's sharing, but an unfortunate fact because it turns out if hospital A knows that they'll benefit even if hospital B contributes, and even if they contribute nothing, and it turns out this often creates what we call a free rider problem. It creates a problem where people underinvest in this upstream stuff. So let's just click on through and go to the next slide. Now, when you face a free rider problem, and a lighthouse is a classic example, you think about it, if you don't come together as a society and finance a lighthouse at appropriate scale, then all kinds of ships are going to crash into the rocks. So that's the illustration of a free rider problem. You do have choices when you have a free rider situation. Click. You could play king of the hill and go it alone and try to find your own food bank and try to make your own medically tailored meals. Sorry, my voice is reacting to. I live in New Orleans now, and I'm told that New Orleans has 3 allergy seasons, and this is the middle one. We have different allergies down there. Anyway, you could play king of the mountain. You could do it on your own. And that's what Americans typically do. And that's what healthcare organizations in particular typically do. They compete with each other. But you could also you could also gather together around a proverbial table, convened by someone like United Way of Greater Cleveland, who can play a very important role we call the trusted broker. And folks can collaborate, what a concept, and end up serving their self-interest in addition to the collective interest. And that's really what our model is about. Next slide. So the key elements of our model, the collaborative approach to public good investment, is first, all the participants, all those who might potentially benefit, all the participants in that roundtable need to recognize what the free rider problem is and know that if they don't figure out how to collaborate, they're going to suffer the consequences of that. So you need to have a group willing to meet and do that. And you've got to have someone who can convene them and someone who has their trust, sufficient trust. We put it in quotes and call it trusted broker. And I'll tell you a little bit more about that role in a moment. So let's click again. So the key elements of the model here is that the folks around the table have to agree on what they want to pursue together. What do they want to try to accomplish? Which social determinant project do they want to explore? Then they individually and sequentially and secretly reveal their willingness to pay, not in public. Because again, if hospital A sees what hospital B will pay, or health plan A sees what health plan B will pay, they'll offer less. If no one knows what the other people are bidding, each of them focuses on what would this be worth to me? What would it be worth to make sure that my enrollees or my patients or my citizens had better nutrition, et cetera, and social isolation intervention, they reveal to the trusted broker only what they're willing to pay. And that way, we keep the potential free rider problem at bay. The trusted broker is the only one who knows the true cost of the project. If the sum of the bids exceed the cost, then by definition, you've got a project that's economically worth doing. And then you can assign what we call, and there's a technical term for this, but I can go through it in detail, but in game theory, it's a fair price. We can assign a fair price in such a way that everyone actually ends up better off than they would have otherwise. And those prices then allow the project to go forward. The money flows from the stakeholders to the trusted broker, to the service provider, and then the value and flows to the stakeholders, and the data flow among everybody so we can evaluate the performance. And fundamentally, the concept here is if the sum of the bids exceed the cost, then this bidding process can be self-sustaining based upon enlightened self-interest. Enlightened in the sense that each organization knows they're going to benefit. They also know others are going to benefit, and they're okay with that because they've realized they're better off individually if they collaborate together. Next slide. So here's a concrete example. Think about medically tailored meals, and suppose the cost is roughly $3,000 for 10 meals for 26 weeks. Click again. And so what the bids might come into the trusted broker, keep clicking, a couple more times, one more time. Okay, so suppose healthcare, and healthcare here is a summation of health plans, of hospitals, clinics maybe, whatever. Government employers, that could be employers recognizing that if folks get nutrition, remember Dabney focused on those folks 50 and above, a lot of them still working. They have fewer days missed from work, so it's actually worth something to employers to make sure this happens. And of course, philanthropy may care because they actually care about people, and they're going to be willing to put some money in the pot. You add that up, you got $3,300 contributed. You only need $3,000, so click again. And because you collect, or you had a bid $3,300, you only need $3,000. You can assign everyone a price that's only 91% of their bid, so they are asked to pay less than they knew the project was worth to them. Click again. So when we do that, keep going, click, good. One more time. All right, great. So if you assign everyone a price that's 91% of the bid, then you collect exactly the right amount of money. Click one more time. You collect exactly the right amount one more time. And what you get then is enough money to pay for the project, but the value being delivered is greater than that, and that bakes in a kind of ROI, or return greater than what they paid, which makes them willing to come back for more. And that's really what makes the model potentially sustainable over time. So next slide. Okay, so what have we done in life so far? Well, Cleveland, as you're learning today, did medically tailored meals for socially isolated older adults with specific chronic conditions. And they're our poster child, our best example. And part of that is because of the incredible skill of Dabney and her team at Benjamin Rose, but also the amazing functionality and managerial capacity and vision of United Way of Greater Cleveland, and that's represented by Jen Kahns, who you will hear from in a moment. In Albany, New York, they recognized their fundamental problem. This started when COVID shots were becoming available, but a lot of people, you may recall, were hesitant about getting those shots, not politically in this case, but historically hesitant to trust a healthcare system putting this new vaccine in their arm. And in Albany, they gathered together and got plans in hospitals to work together and put about 40,000 shots in arms that would otherwise not have been vaccinated. In Waco, Texas, they recognized there that their fundamental biggest problem community-wide was access to mental health care. Police chief down there told me 80 to 90% of 911 is related to either a behavioral health crisis or substance use disorder. In Texas, and maybe lots of places, 911 means policeman's got to go. And so what we did was put a social worker in the police department to do triage on the calls that were coming in addition to providing complex case management for people who were recommended by a health plan. So two different arms of this endeavor. But the point is complex case management for families with someone in behavioral stress. And it was a great success. The police chief basically ended the experiment after 2 months, hire the social worker. It cost me a publication, but it's good for America, so I'm in favor of how that worked out. Okay, so that's how we've done it around the country. Next, click again. And I want to say, when you implement CAPGI, when you do this, it's as much about the governance process, folks learning how to share information, to keep important proprietary information secret. That's why the trusted broker role is so important, as well as the data flow being protected. But at the same time, it's really about a governance process to get you to a collective decision that ends up improving the welfare of a number of organizations, not just one. Click again. It's about, at the end of the day, what I tell people I do is I teach Americans it's okay to collaborate even though they're Americans. A lot of people think you're supposed to compete like crazy and beat the other guy. Well, that's something you can do in some dimensions, but in particular, upstream of the healthcare system, most organizations are far better off trying to collaborate and do it together. They can be more effective. One more click. And what you want to do is move the people around that proverbial stakeholder table away from thinking about charity upstream and think about operations. Fundamentally, these kinds of activities are in the self-interest. The reason Bob Blancato's summary of the promise, the medically tailored meal legislation, is so real right now is precisely because folks have figured out, hey, you know, this is worth it. It's really a smart thing for us to do. And that's why we're a lot of us are optimistic. This movement is going to take off. One more click. And I think it's important to state the trusted broker can be many different organizations. In Cleveland, it was the very effective United Way. In Albany, New York, it was basically a group that had come together to manage data and manage negotiation for community-based organizations with health plans. So they had earned a kind of a broker status before we showed up. In Waco, Texas, it was basically a chamber of commerce, which turned itself into this social thinking operation that said, what does our society need? What does our community need? And it's called Prosper Waco. And they really are mostly the big employers in McLennan County, thinking about what's important for them all to do together. The point is, different organizations can be a trusted broker. All of them have to have the characteristics of the United Way in Cleveland, and that is they have to have credibility on the ground, they have to have the trust of the local stakeholders, and they have to have managerial capacity to make sure these contracts are honored and folks live up to their obligations. So one more click. And so here's my contact information. I'm pretty sure you'll get these slides. Those 3 links at the bottom there are papers that have come out in the last couple of years, which can give you more detail. And the link in the middle to the CAPGI Urban website has a 4-minute video which explains everything and gives you the history of our contributions. So thank you very much. Ashley, I'll turn it back to you.
Thank you, Dr. Nichols. All right, so we are going to now hear from our final speaker for the day, Ms. Jennifer Kahns. She directs the United Way of Greater Cleveland's strategic initiatives, including new endeavors with the 211 helpline and projects that align healthcare and social services. Her prior experience centers on individual and systems levels approaches to aligning health and social needs with traditionally under-resourced communities. Ms. Kahns has managed programming and fundraising at a community health center and worked with ethnic and community organizations across Illinois on public benefits access and implementation. Please join me in welcoming Ms. Kahns.
Hi, folks. Thanks for having me. It's a pleasure to be here today, and I appreciate the invite from Ben Rose and the Elder Justice Coalition. And it's always a pleasure to follow Len. He's such a great hype man. So thanks, Len. So I'm Jen Kahns. I'm with United Way of Greater Cleveland. We can go to the next slide. And we played this intermediary or trusted broker role in this endeavor with Benjamin Rose and what we refer to as our investors in the project. So as the trusted broker, I kind of think about our role in 3 different ways. We recruit and we maintain relationships with our investors or stakeholders, and we administer the project. That includes the bidding process as well as the intervention. And then we support evaluation, and that includes data flow, legal agreements, and the working with the evaluators. So I'm going to talk mostly about those 3 roles. I'll try to keep it short so we have some time for Q&A. So we can go to the next slide. Len really kind of hit on this, but I think about CAPGI model as like there are buckets of dollars, but nobody maybe has enough or nobody's willing to put their money in. And so if you go 2 slides forward, the model really, through the trusted broker, we kind of unlock those locked up dollars and are able to funnel those to an agency to make investments to address health-related social needs. So it's this kind of pooling of resources that would otherwise maybe not come to fruition. So it's about the money, but it's also about shared governance, which Dr. Nichols alluded to as well. I think in the shared governance, by working with multiple investors, whether they be multiple health insurers or multiple providers or foundations, they don't just hear about their own priorities, they hear about one another's priorities as well, and they start to understand one another's priorities. And there's something a little magical that happens where when folks that have always been kind of touching the same people and working with the same populations start to understand each other and their business models a little bit better, and that kind of creates some more, like opens the door for more solutions. So go to the next slide. So in our first cycle, so we're in our second cycle of this intervention. In our first cycle, we had 11 investors, so 11 organizations that bid and contributed money. 5 of those investors actually referred their own managed care members or their own health system patients, attributed patients to the intervention. And you can see kind of who we targeted. Overall, this enabled Benjamin Rose to deliver over 80,000 meals. And we had close to, I want to say close to 400 people actually participate in the intervention. We're really looking at folks who stayed in for at least 3 months or 12 weeks, and we hit a little over 200 there. So we can go to the next slide. So we started with the end in mind, and this was really about how can we demonstrate that there is financial return on investment if around health-related social need interventions. Is there an ROI? How do we document it? And so people went through the intervention. We also asked those referring investors to share cost and utilization data for the people who participated, as well as for a control group. And so we had these data sets from each of those 5 investors, and we're able to work with Len and some external evaluators to pull those data sets together and do some robust statistical analysis, which is not my forte, is Len's forte, to see like, did we have ROI? And so what we found is that there were lower costs associated with the intervention group. It wasn't enough necessarily to pay for the whole intervention, so it didn't pay for itself, but it did generate substantial savings. And we'll talk a little bit more about what else we tried to suss out about those cost savings and about the intervention. So we can go to the next slide. We wanted to understand where we saved money and who persisted and why it worked and how it worked. And so we really worked with the investors on a series of kind of explorations about what we had just done together, about people who had participated in this intervention. And I think the special sauce is that they really helped design what those explorations would be, based on their questions and our questions together. So we did a series of interviews that they designed, and we learned about who was most likely to opt in, who was most likely to opt out, or who was most likely to cancel, and why that was. We did a process review, and we came up with some ways to make improvements in the process. We also looked at our own retention and who stayed and who didn't stay in the project and why that might be. And then we piloted a survey. In that survey in particular, we found that affordability was the most common barrier for folks before the intervention, most common barrier to healthy eating. And it was really interesting for the group because I think a lot of the investors saw this very much as a nutrition intervention, which it is, but the participants clearly saw it as a food accessibility intervention, a food security intervention, which is different. So for us to understand why someone might be interested in it, whether or not we think they need it, that really helped us understand that. And then we did a comparison around each investor, who they targeted and how they screened people into the intervention. So because they were all responsible for identifying and opting in their own people, they did it in slightly different ways, and we were able to see kind of who was more successful and what their methods and tactics were that created more success. And so we can go ahead 2 slides. So the other thing is that I think was really valuable is that because there's a group of investors and there's an intermediary, us sitting in the middle with Benjamin Rose and with Len and Lauren, is able to have more discussions and feedback loops about what is happening. And so what we ended up eliciting was a lot of assumptions about why people thought it was working or not working. Particularly the investors, when we had folks that didn't stay in the intervention or that chose not to participate. The first assumption was that, well, it's because people don't like the food. It's because it must be, gross, highly processed food. And what we, in conversation and kind of sharing that assumption with Benjamin Rose, the feedback was, well, maybe it's also that people aren't used to a medically tailored meal and we need to do a better job of prepping them, which seems fairly obvious, but I think there's not always opportunities for those 2 sides to have that kind of open conversation, especially with some power dynamics, which we'll talk about in a little bit. So part of our role as the trusted broker sitting in the middle is to listen, investigate, refine solutions. So what we ended up doing was prepping the investors to do a better job to differently talk about the intervention and why it might appeal to someone during the process of enrollment. And what I can say is that now that we're in our 2nd cycle, we have much higher retention rates. We've not only showed that there is some opportunity for cost savings, but we've showed them how to do a better job at identifying and enrolling people in an intervention like this. We can go to the next slide. So I'll get back to evaluation. So throughout our process over the 1st cycle, we really evolved how we thought about the evaluation. And that, I think, as everyone's values became a little bit clearer. So everyone, at first, our end goal was financial return. And can we look at data from the intervention period and per member per month cost? Can we see a change? And so we built a model to do that. And then we said, well, maybe we should look at health. And so we worked with another partner to suss out, like, how would we measure health? And we actually decided not to measure health in a traditional way, that it really wouldn't work with the intervention. And so instead, our investors said, well, what about let's evaluate their experience of the intervention and what they like and don't like about it. And so we built some tools to do that. And then finally, when we decided that we weren't going to measure health, we said, well, can we measure kind of shoots of health, shoots of healthy behavior, changes in attitude? And so we built some additional tools to measure that. So I think that this evolution is kind of very common right now in the healthcare space, in that we're talking a lot about return on investment, financial return on investment, but there is a push to say, well, maybe it's not all ROI, or can it be ROI and something else? Or what if the ROI is 80%, but we're making huge strides in engagement in primary care and self-efficacy and in community change? Like, aren't those things as important? And maybe that balance, there should be some balance with just financial return. So we can go to the next slide. So like I said, we are in our 2nd cycle. We decided to apply our lessons from the 1st cycle, update our evaluation. We're also doing some things where we're doing some cost and data sharing between the referring investors. And then our goal at United Way is really to transition this to Benjamin Rose. It's been lovely to have the privilege of kind of sitting in the middle of this work with them. But over the long haul, like, they don't need United Way to contract directly with healthcare payers and providers. And so it is our hope to try to set them up for success and create step back from those relationships and allow them to work directly with payers and providers. Go to the next slide. I'm almost done. So just to kind of recap, I think there's a lot of kind of generally accepted nuts and bolts about what needs to be in place to have contracts between CBOs and payers and or providers. So we need contracting and payment. We need to figure out how we're going to manage referral processes. We need some technology, and we have to make sure we're HIPAA compliant. And those definitely, all those things. But our local experience has also showed us that evaluation is critical. And yeah, I can talk about the AAA. Sorry, I see the chat. So evaluation is critical, and it helps us talk about what we want to get out of this intervention and helps bring that conversation to the forefront. So not just to find the endpoint, but to figure out what endpoints we're interested in. I think it was really valuable to have us as a sort of translator between the world of healthcare and the world of social services, where we have different business models and we speak different languages. And then finally, having, there is a very significant, at times, significant, can be power imbalance between the healthcare sector and the social service sector. And to have a trusted broker who will also leverage their relationship and advocate on behalf of CBO value, and that they're more than just a vendor, but there are other things that they are bringing to these interventions. There was a question in the chat about the AAA, and we did have our AAA, our local AAA, as an investor in our first cycle and sitting at the table and being part of those conversations. So that was really helpful to have them there. If you get the deck afterwards, in my next slide, there's a couple of resources about emerging models around these kinds of contractual arrangements. So check that out, check out those links. But otherwise, I'm done, and I'm going to turn it back over to Ashley. Thanks so much.
All right, thanks everyone. We did have some questions coming into the chat, so we are going to take a few minutes to do some Q&A. You do still have time to submit a question either in the chat or in the Q&A if you would like to. So I know that we did answer the one about the AAAs. And just a reminder, we did have this question come up a little bit. You guys will be sent a copy of the slides and a recording of the slides as well to everyone who registered, and please feel free to share those. Dabney, when you mentioned the count 1 to 3 ratio of chronically ill adults unable to afford the meals, they just said that that was an incredible stat, and they were wondering if maybe you had the reference for that so they could, you know, get a little bit more information.
Can we have you send that out with the materials? Okay, we'll
Absolutely.
do that.
Yep.
Okay.
So we'll get that from Dabney and send it out to everyone, so that can be easily referenced. So let's go on over to the Q&A. And then there was a question also if we could include the link to the PubMed.
And that's in the slide deck, but I will pull it out.
It's in the slide deck. Okay.
Mm-hmm.
Let's see. And this one said, what grant would pay for medically tailored meals, Medicaid, but not C1 or C2, right?
I think that's a Bob question. Maybe.
You're muted, Bob.
4 years later, I still can't find the button, you know.
Same.
C1 and C2 are not there yet. You know, I think that's part of what we're looking at in the reauthorization to broaden the scope of what could be covered under congregate and home delivered meals. Medicaid and Medicare are more likely candidates, and demos are more likely to be tried there. But, you know, the idea is to spread a wide net out and see how many, you know, entities and programs you can get in there. So, but it's certainly on the radar for sure, as Len mentioned before.
Thank you. And I know,
I'll add that we, you know, we didn't bill for Medicaid, but investors, I think the time was right that folks saw coming down the pike the need to be screening for health-related social needs and addressing health-related social needs. And so they were looking for opportunities to do that and pilot projects. And so from our investors, some dollars came from a plan's foundation side, some dollars came from the administrative portion of their Medicaid budgets for plans. Some came from hospital foundations or also from operating, right? So I think it didn't need to be tied to a reimbursable thing. I think folks can find resources to invest in the things that are in the direction of where their business is going.
Yeah, I think more people recognize it's in their interest, but I think it is true that the policy environment is really important. Medicaid strongly encouraged each payer there to investigate how to do social determinant interventions, and food was one of the things that they were encouraged to do. So that definitely created an environment. I would say Medicare Advantage plans are kind of there. They figured it out. And they are able to do it now in a number of different ways. But hospitals at the moment aren't. And so that's where the payment stuff really, really matters. And what Bob is doing in DC is extremely important, because what you really want is fee-for-service Medicare to join the party. So you can actually have everybody doing it, not just the plan.
Thank you.
Stephanie, were you going to add?
All right. I know that this one was kind of addressed several times in different ways, but maybe someone could just expand on it. The participant was wondering if the program was mostly tailored to low-income individuals.
So I can take that one. It was not. The idea is that we built this structure that it is a universal program. So it is not meant for just low income older adults. It is a program that you could sit in any population that are chronically ill and need medically tailored meals.
Thank you. And Jen, someone was wondering if you think the model will be promoted to United Way nationwide.
Sure. So if you've met one United Way, you've met one United Way. We're all a little different. I have shared this model. I've presented it with some folks from Worldwide. I think it is such a kind of United Way thing that we take resources and pull them together and work with partners to invest in the community. I mean, that's kind of what United Way does day in and day out anyways. I don't know. I'm happy to share with any local United Way that is interested in the model and how they can make it work. But it did leverage a lot of our existing relationships that we had, and was able to bring in some new ones as well.
Thank you. A couple more questions. So we had someone that asked if there was a way to make sure that medically tailored meals are also culturally tailored. Is that possible?
Bob, were you gonna?
No, I wish I would. I wish I could answer. I mean, one would think there's a relationship, but how you would orchestrate that has a lot to do with how the meals are prepared, things of that nature, which I'm not that familiar with.
So I'll speak to that really briefly. There is a way to do that. It comes down to the relationship that you have with the caterer. And so the caterer's ability to be able to navigate, to create the appropriate menus, to have the right type of kitchen facilities would make you answer that question, yes. But I think the first question is what is the caterer's capacity to be able to create those culturally specific meals? And then also, I think the secondary piece would be understanding going in that those culturally specific meals may not get to scale at the same level that a universal meal would. And so it's a false errand if you start out the gate saying we need to get culturally specific meals to the scale that you would get your universal meals, because you won't necessarily get there, because you're being culturally specific based on whatever community or culture you're attempting to respond to.
Thank you. So we are running short on time, but I did want to quickly get to this one, as I feel like it's really important. Someone wanted to know, is this meant to be a long-term program or just a short-term program, which then relies on the individuals continuing this type of healthy eating?
Jen, you want to go?
Sure. I think we meant to do a pilot to have a confined group that we could measure, do evaluation on. But I think the idea of medically tailored models, certainly as delivered by Ben Rose, fits lots of different scenarios. And for some people, that could be a meal as long as they are remaining in their home. And for some people, that's a short-term intervention, 6 months, a year, 18 months, until they have learned some tools, learned some information about a healthy diet and how to prepare that for themselves. So it really varies. And I think that's part of the value in working with investors that are payers and providers and kind of sussing out who is this a good fit for within their populations, or how does it fit within their populations.
Thank you. Did anyone want to add to that or have any last minute thoughts before we close for today?
I was just going to say, if you go back to Dabney's point about how the program was not designed specifically for low income, and Jen's point that some people were food insecure in addition to needing medically tailored meals, what you want is for the folks who can afford it to learn how to buy what they need, and for the rest of folks to figure out how we can get them food forever.
Thank you. That's a great point. Okay, well, I want to thank all of our presenters today for sharing such great information. Thank you to everyone who joined us today. In the chat, you will now find a link for a webinar evaluation that we hope you will complete. Your feedback is important to us as it helps us to improve our programming. Your responses will be kept confidential and will not identify you in any way. We hope that you will join us for future events. We will be offering our 4-part homebuyer education series from 6 to 8 p.m. Eastern Standard Time, Monday, March 25th through Thursday, March 28th. Our free HUD-approved homebuyer education class teaches the important basics of the home buying process. On Wednesday, April 10th from 9 to 10 a.m., we will have our monthly virtual Second Wednesday. Second Wednesdays are a great opportunity to network, learn more about Benjamin Rose, and discover how you can get involved in our work. Please also join us on April 10th from 12 to 1 for The More You Know Hoarding, a free 1-hour Q&A session with professionals who will explain hoarding disorder and provide useful information. You can register for these and all of our upcoming events on our website, www.benrose.org. There you can also find more information about all of Benjamin Rose's research, services, and programs. Thank you, and we hope you have a great rest of your day.